Hello, in this video we're going to review TPN, Total Peripheral Nutrition. So indications for TPN would be any kind of damage to GI tract, damage to the point where feeding through the intestines, enteral feeding is not possible. Some of the conditions that can cause that would be paralytic ileus, mesenteric ischemia, small bowel obstruction, and intercutaneous fistulas. So again, some kind of GI damage, GI needs some rest, intractable nausea, vomiting, or diarrhea, small bowel resection, and some radiation to the intestines. So some of the things to remember with TPN would be when fats are added to the TPN, it reduces the need for glucose. So this is a 3-in-1 solution, probably has dextrose and proteins and fats. While if there's one bag white and another one bag is kind of yellow, then you can conjecture that it is a 2-in-1 solution. Fats are separate and proteins and glucose would be in another one. So fats are supplied as egg yolk, phospholipids, or glycerol. Also 20% fat provide 2.2 calorie per milliliter. We can administer separately or concurrently amino acids dextrose solution via white tubing. So it's important to remember that when you initiate the infusion of TPN or fats, you have to start slowly. If it's a 10% fat solution, start about 1 milliliter per minute, which rounds up to 60 milliliters per hour. And then if the concentration of fats is 20%, then start at half a milliliter per minute. That is 30 milliliters per hour. So with TPN, we will use filters. So if it is just proteins and dextrose without fats, we will use 2.2 micron filter. And if we're using fats in our TPN, we will use 1.2 micron filter. So tubing should be changed. Sources vary, but what I found on one of the sources, change tubing without lipids every 24 hours and change tubing with lipids every 12 hours. Well, it depends on every facility and, guidelines change. So monitoring, before hanging the bag, check if there's any particles flowing in there or if there's any leaks. If there is, just send it back to the pharmacy and get a new one. Also, we will monitor for the bloodstream infections, all the signs of sepsis and temperature and so on, redness at the site. Also to remember with vascular access devices, the dressings, I think the standard is to change the dressing every 5 to 7 days if it's a transparent dressing with special kit for the PICC lines. And if it's a gauze dressing, which is not special for the PICC lines, then it's changed every 2 days. I think that's what I got from one of the websites. Also, we will monitor serum albumin, protein, electrolytes, glucose, chemistry profile when giving TPN. So the goal is to provide therapeutic nutrition to the patient and make sure their electrolytes and proteins stay within normal limits. And so we just watching for the response. Is the patient getting weight? Is the patient patient's electrolytes are stable? And is the albumin within normal limits? and are they healing? Are they fighting the infection well? So anyway, so blood glucose checked every 6 hours, and serum glucose must be maintained between 140 and 180 milligram deciliter. And glucose is very docile element to monitor with total performance nutrition. It can change very drastically during the beginning or during the end of the TPN treatment with the TPN. So in the beginning we have all kinds of repeating syndromes, rebound hyperglycemias, patient cannot tolerate the glucose well, or they can be diabetic, they can be older age. So it's important to monitor glucose in the beginning of the TPN and then initiation at the end of the TPN, because if eventually the patient is getting off the TPN and they abruptly stop the TPN, there can be that rebound hypoglycemia where insulin is still produced at large amounts, but we don't have sugar or glucose in the patient to push into the cells and match the insulin amounts. There's all this hypoglycemia with all the shakiness and signs and symptoms of diaphoresis and so on. So monitor the sugar, the hyperglycemia, hypoglycemia, such as signs polydipsia, polyuria, kinds of confusions. And also we will monitor fluid volume overload, especially with cyclic peripheral nutrition, where total peripheral nutrition is given in cycles. It's given over 12 hours, for example, during the night, and then the patient is good for 12 hours during the day. Or they might somehow supplement it if they can't orally during the day. But anyway, large amounts of TPN given a short amount of time, and the patient must be able to tolerate that. In order for the patient to tolerate that, they probably should not have any heart issues or kidney issues. And so we will monitor for fluid volume overload. So there we go, rebound hypoglycemia. So after discontinuation of cyclic peripheral nutrition or interrupted start, for example, a patient, goes for a procedure where they don't want the TPN to be running and or something, patient went to the bathroom and then come back and then hook himself up. The nurse did not hook the patient up. So there's a continuous secretion of insulin, and that glucose dramatically depletes, and that leads to hypoglycemia, which is blood glucose less than 70 milligrams per deciliter, 100 milliliters. So prevention: ensure no interruption of infusion or cyclic infusion. So you don't want interruption at any, continuous or cyclic. And with cyclic infusion, taper down over 2 hours before you want to stop it. So gradually reduce the rate. Then hyperglycemia can occur in older age sepsis with hypokalemia and hypophosphatemia. So important to monitor these patients. And of course, treat appropriately or provide less glucose. So they don't know why, but patients who get TPN for long periods of time, they can be at risk for hepatic function abnormalities. They might develop stenosis, and they can develop cholecystasis, gallbladder stones, and it's important to monitor their alkaline phosphate and transaminase levels. So all kinds of electrolyte imbalances. We might be giving too much electrolytes in that TPN, we might not be giving them enough, or there's this refeeding syndrome where in the beginning we initiating the TPN, and if the rate is too high with glucose, the insulin starts pumping into the system and pushes all those electrolytes, all that sugar out of the circulation into the cells, and so the patient loses all his potassium, magnesium, phosphorus, and develops signs and symptoms related to that. And the worst are respiratory complications, lungs fill up with fluid, and then kinds of neurological alterations, arrhythmias. So not a good thing. So anyway, intervention requirement monitoring of serum electrolytes. Decreased potassium in the serum results from potassium being pushed in the cell together with insulin. Spasms and EKG changes will be evident, so keep them on electrocardiogram monitoring device. So increased potassium can occur with renal impairment, with metabolic and respiratory acidosis, when potassium shifts out of the cells. So treatment reduces amounts of potassium in parenteral nutrition solution. So decreased magnesium, magnesium can go down. The same thing, it's driven into the cells together with insulin. So cause can be GI losses of magnesium, refeeding after starvation, renal disease. Signs and symptoms could be apprehension, depression, apathy, neuromuscular, hyperexcitability, tremors, PVCs, tachycardia, and pulmonary PVCs, and ventricular fibrillation. So supplement with magnesium, add some magnesium in the TPN. Phosphorus, basically the same thing, pushed into the cells with insulin, and supplement with additional phosphate. Okay, refeeding syndrome. So occurs when the body adapts to nutritional deprivation and decreases basal energy requirements and diminishes cardiac reserves. So body adapts, secretes less insulin, and kind of reserves that sugar, keeps it in the bloodstream. So when refeeding is undertaken too aggressively, it leads to electrolyte shift from the plasma to the intracellular fluid and can result in hypophosphatemia. Cardiorespiratory complications can occur. Signs and symptoms would be increased heart rate, increased respiratory rate, advancing heart failure, and can even lead to cardiac arrest. So the thing is with all the signs and symptoms, I kind of wondered where they coming from. All this exacerbating heart failure, how does phosphate would play such a role in it? Well, it seems like there's an exchange when so when phosphorus, potassium, magnesium is pushed into the cells together with insulin, it is exchanged for sodium. It's exchanged for sodium, and what the sodium does, it draws water. And when it draws water, fluid overload, and water fills up in the lungs, pulmonary edema. You'll see, water fills out in the legs, arms, and repeating edema there. So there you go, signs of symptoms of heart failure. And it's all stress on the heart. If the patient had heart issues, they also will have heart complications. Also, one thing to mention while we talking about refeeding syndrome is that there's thiamine, the vitamin in the patient's serum, and if we give glucose and all the nutrients, just dump it into the person while they're in starvation mode, insulin will be released, and when insulin is released, there's catabolic and anabolic processes will start to undergo, which is that the body will aggressively start to repair and rebuild. When this repair and rebuild is being done, thiamine is used, that vitamin is used, so it also is depleted in the system, and it happens that thiamine is used for ATP production, and if it decreased, we can't do that glycolysis and use Krebs cycle. So you need thiamine to do the Krebs cycle and break down those fats and make the energy out of them. So when that happens, body will start shunting glucose through lactic acid. Glucose shunt to lactic acid, and so lactic acid will lead to lactic acidosis and rhabdomyolysis there. So the muscles will be damaged by lactic acid, that large amounts of lactic acid, and you'll see signs and symptoms of rhabdomyolysis, muscle pain, and kidney injury, and brown urine. Alright. So when feeding a malnourished patient, stimulation of glycolysis occurs, as well as other anabolic and catabolic processes. These processes will utilize a lot of electrolytes to make ATP. Phosphate will be used. In a malnourished patient, it will lead to low phosphate levels. Low phosphate levels lead to confusion, respiratory depression, cardiac arrest. Also, patients with liver resection will also be at risk for hypophosphatemia. So what do? We supplement with phosphate. We supplement with thiamine, folate, and multivitamins. Sometimes the physician prescribes the multivitamin to be added to the TPN, so the nurse will draw it from the vial and then just inject into the bag. Also to remember that the TPN usually is stored in a cold environment to preserve those vitamins, and if it sits around for 30 minutes at a warm room temperature, then those vitamins start to break down. So IV fluids such as lactated ringers or PO fluids, I'll supplement with that. Slowly initiate the nutritional rehabilitation, and restrict the sodium, because that sodium can shift from the cells. Also, we will monitor the electrocardiogram to see if those electrolytes are causing any issues. And first it should be continuous over like 72 hours, and then it might be just reserved for the night if the patient as the patient gets more stable. We'll monitor the labs, all the BMP, magnesium phosphate, for at least first 4 days. What else to mention? So there's ways to calculate the TPN. Well, I can say that so for a malnourished patient, we will start with 20 kilocalories per kilogram per day, and that would account for 75 kilo standard patient. It would be what, 75 multiplied by 20, you would get 1,500 kilocalories per day. So that's what you start with, and then you calculate all the percentages of protein, fats, 30% of fats, and the rest. And then what other electrolytes have to be adjusted in that TPN. Also, if it's stable, just a trauma patient who was not malnourished, who just like some kind of injury to the gut and like there's need for the gut rest, it's 30 kilocalories per kilogram per day. And I think that leads to something like, what is it? Was it 2,250 kilocalories per day. Okay, and if the patient is a stable patient who was, a patient who was not malnourished, and they sustain a burn to their large amount of burn to their body, then they will need increased requirements for food, for nutrients, and also protein, and those patients should get more calories. So they will go 40 kilocalories kilogram per day, and well, I think that's about 3,000, right? It's all calculations for 75 kilo patients, so I think it's 3,000 calories. There you go, kilocalories day. So you have just made it to the end of the video. If you found the video useful, please click that like button. I hope you enjoyed it. Thank you for watching, and I wish you great success.